My co-chair, I would like to introduce Dr. Mitra Kumar, Senior Interventional Cardiologist, and we'll be chairing this session on most exciting field in interventional cardiology, STEMI interventions. I think this is one of the most satisfying, gratifying results we get once an intervention is completed. And today, the next 20 minutes, there will be a case-based illustrated discussion from Switzerland. I welcome you all for this session, and Dr. Mitra Kumar will introduce the speaker.
Next speaker is Dr. Florin Chuchiai. He is Co-Chief, Department of Cardiology, Head Interventional Cardiology and Acute Cardiology Heart Center, Lucerne, and Lucerne Canton Hospital, Lucerne, Switzerland. Head Cardio Center, Lucerne, AGI, Lucerne, Switzerland. His research interest is in the field of interventional cardiology. We welcome Dr. Florin Chuchiai.
Can you hear me and see the slides?
Slides not available.
I shared the slides now, the screen. So
it's connecting. Wait a minute. Yes, now we can see your slides.
Great, and you can hear me?
Yes.
Okay,
Thank you.
So I can start. Thank you very much for giving me this opportunity to speak to you. It's my first time I speak to the Sri Lankan community and in cardiology, and maybe we can do this also one day live when Corona is over. So what I will show you today is the modern treatment of patients with myocardial infarction and with cardiogenic shock. And I'm aware that I will be able to show you maybe some things and some tools you don't have, but I think we have to think about the future and how we can improve cardiology. As you all know, there are certain complications of myocardial infarction. Of course, we have some mechanical complications like ventricular septum defect, papillary muscle rupture, ventricular rupture. Then, of course, we have tachycardias and bradycardias, and we have pump failure. So acute heart failure, or as you can call it also, cardiogenic shock. Probably as a result of the acute treatment, most of the times, we have late problems like heart failure, we have late arrhythmias because of scars, and we have the problem of ventricular aneurysm or valvular dysfunction when we have for example, a large inferior myocardial infarction which we treated late or did not treat perfectly well. Now, when the heart is failing, what can we do to make things better? This is like when your horse is just not doing what you want because the horse is sick. Of course, you could whip the sick horse and try to do your job, but you know this will not last long. You could unload the wagon. This is sometimes possible, sometimes it's not possible. You could, of course, get a new horse if you have the money to buy it, but it's not always easy to get a new horse and to have the money to buy the new horse. And then you could get a tractor, or you could heal the horse or slow the horse. So what I want to focus today is on the tractor, to get a tractor until the horse is doing better, and then ask the tractor to be removed and then go back to the horse. You all know, and I'm sure this is known to many cardiologists, that if you start to use catecholamines in your patients with acute myocardial infarction, you might sometimes be able to save their life, but you will always destroy their heart with catecholamines in the acute myocardial infarction setting. So the patient might survive, but he will have a significant damage. And if you have to add a second catecholamine, then you can see here that actually mortality rate increases dramatically. What are the options we can use to support hearts when they are failing in the acute setting. One option on the left is the Impella, and the other options on the right on the screen is the ECMO. These are the two options you can have. Now, Impella, this is what I am using most frequently, is a pump. You can insert it via the femoral artery into the heart, and you can support the left ventricle with about 4 liters per minute of cardiac output, which you can generate through the pump. Of course, nowadays there's also a right heart Impella, but that's something which is not really used very frequently even here. So in my case, I've used it once, and we can speak about that maybe in the discussion. With the Impella, I have made the experience that you can actually really overcome the trouble you have within the first days, because usually the patient then after a few days starts to stabilize. And in my hospital, it's basically forbidden to use catecholamines during the treatment of acute myocardial infarction. So we really rely mainly on mechanical support if needed. Of course, before we go to use mechanical support in cases in acute myocardial infarction, you have to gather experience with these devices in more stable patients. This is one of my patients which I've been treating like 10 years ago. You can see a massive left ventricular dysfunction, dilated left ventricle, and this is his last remaining vessel. The rest is dead, so the anterior territory is dead. This is the LED you see there, but he has a highly calcified stenosis on the right coronary artery, his last remaining artery. So in this case, we put an Impella, CP, a big Impella, and we treated this, and you can see we achieved a good result. And this allowed us to really give us enough time to spend time and to treat it the way we wanted to do it. If we go back to acute myocardial infarction, if you have a large, especially anterior myocardial infarction, but sometimes in a dominant circumflex also a posterior myocardial infarction or inferior, usually you will have severe myocardial dysfunction, and this will lead to a systolic and to a diastolic dysfunction. Now, if we go and focus on the systolic, you will have, because of this, less cardiac output. Less cardiac output means less blood pressure. Less blood pressure means vasoconstriction, also of the coronary arteries, of the other arteries, of course, then increasing afterload. You will have tachycardia. This is automatically happening. And you will have also less coronary perfusion. This will lead to ischemia, so more ischemia, worsening myocardial dysfunction, and of course to cardiogenic shock. And you will start at the top again because it will aggravate the symptoms. Then on the diastolic part, you will have increase of LVDP and wall stress. And we see sometimes cases with a LVDP of 40, 45, 50. And you will have, because of this, of course, pulmonary congestion and hypoxemia. So you will have also more ischemia and worsening myocardial dysfunction and also more cardiogenic shock. And this will all start at the top. Now, what we are trying to do and what I believe truly needs to be done is we really need to work on both sides. So on the systolic side, we have to increase cardiac output. We have to increase blood pressure in order to have less vasoconstriction, less tachycardia, and better coronary perfusion. This will lead to less ischemia, better myocardial function, and of course, less shock. On the diastolic side, by having the blood pressure relieved or the blood relieved from the myocardium, you will have less LVDP, less wall stress, so less ischemia, and of course, less pulmonary congestion, which will lead to less hypoxemia. Now, imagine, just as an example, if your diastolic pressure, or if your pressure is 80 to, let's say, 45 in a shock patient, and your LVDP is 35, then you only have a delta of 10 for your coronaries. That's why these patients very often, despite having an open vessel, don't have ST resolution, because they are still ischemic, because you are not able to perfuse the myocardium. This is an example of a patient which I treated 7.5 years ago. The patient was resuscitated with left main occlusion for about 45 minutes. And what you can see here, of course, is I put an impeller after treatment, and this was a small impeller, 2.5. Back then, we did not have the big one. And I additionally put an IABP in this patient, so a balloon pump. And you can see that in the time when the patient is not having the balloon pump running because we put it on standby, there is zero pulsatility. So this patient was without pulsatility for 3 days. Fortunately, he improved, and this is the patient then, this would be about 4 years later after I treated him. And he's still alive. So acute left main occlusion, long resuscitation, several days without pulsatility, and still the patient is alive. And he actually, I don't know if you see it on the background, he's the painter of my clinic here. So he paints all because he's a painter, an artist. So he paints for me, and I'm very glad to have someone like him and to have saved him. I would like to demonstrate to you some cases to just, in a way, stimulate you as well to think, okay, well, maybe Dr. Tsutsuri is not really completely crazy. This is an old lady, 82 years old, with a posterior MI. And she was transferred to us from a different clinic, from a smaller hospital. And she insisted on being treated. And of course, in Switzerland, we have a different system and a different age perception as well. Patients who are 82 in Switzerland are not old. And, we do TAVIs when they are 93, 94, 95. So this is a different mentality, different culture, different country. And the patient requires maximal therapy. And she's really in bad shape when she arrived. And while she was in bad shape, you can see here, well, she has nothing left. The LAD is chronically occluded. The circumflex is acute. The big intermediate branch is subtotal at the ostium. And also you can see the diagonal branch is also very diseased. And the right is small and also almost occluded. Now, how can we save such a patient? I put her on an impeller. Then we treated the circumflex, we treated the LAD, we treated the left main. And after 9 days of ICU, she left the hospital, and she was discharged to rehab after 20 days and recovered well. I saw her many times in clinic. She was doing well for many years. I'm not sure now if she's still alive, but she survived this. This was the final result. You can see here the LV function is not bad. She has an LV function of 45. She has some MR, but this was fine. This could be managed in a conservative way with pills. So it worked. Now, sometimes we have patients like this. This patient is also 80 years old. She has a subacute anterior MI, and she arrives unstable in our hospital. And as you can appreciate, she has an apical thrombus. Now, how can we deal with this patient? Well, this is her anatomy. You can see the LAD is occluded acutely. She has severe left main disease. So you can see also still the ST elevations there. So in this lady, we put her on a balloon pump and on ECMO to just be able to treat her. Then she needed rotulation of LAD and circumflex because it was heavily calcified. We could not cross any balloon. This was how it ended with the treatment. And this is the LAD. Of course, it needed a few stents, and the stents are quite nicely expanded because we had the time also to really work on her and treat her well. And this was the ventricle just before she left the hospital. Fortunately, she actually improved, and I called her recently, and she was doing very well. This is now an old slide. This case is probably now about 2 years later. So sometimes if she has an LV thrombus, then of course ECMO would be an option to treat such patients, and it works as well. In order to convince you that mechanical support is so important, I will show you this case. 50 years old man with left main stent thrombosis, 5 days post-implantation. Of course, we all know 5 days post-implantation has nothing to do with pills. It's the mechanics. So this patient received a left main stent in another hospital. He received a 3.0 millimeter stent in a left main. Imagine that. And he has also a lot of stents in the LAD. So the patient arrived severely hemodynamically unstable. So we put him on Impella. We could not hold him with blood pressure despite Impella, because he was really in bad shock. So we introduced IABP additionally to that and said, let's wait, maybe he will recover. Luckily, because I believe the IABP increased diastolic pressure significantly and diastolic perfusion, so he had some coronary perfusion, he recovered. This was the result initially with the left main occlusion. This was the result later. We actually brought the patient back to optimize the result because here in the acute phase, we just opened the artery and then brought him back for an optimization using intravascular imaging. Now, what do you believe? What was the ejection fraction at 3 weeks with this patient who you can see here? If I go back to the slides, you can see how the heart is pumping. This is this movement of the heart. This is not a healthy heart. I'll show you. This is its ejection fraction. So it's almost normal. So you have a left main occlusion. The patient is really in bad shape. We can even not hold him with Impella and IABP, and still he recovers quite well. So now to conclude, before we reach the discussion, I would share with you my most impressive case of my life. This patient had a heart attack at home, and it's a 53-year-old gentleman. He had an anterior MI. I received the ECG from the paramedics who said, we are bringing a patient. And I said to them, come in. And I drove to the hospital. When I arrived, he was already being resuscitated for 20 minutes, and they could not defibrillate him. They defibrillated many times, but they could not convert him from ventricular fibrillation. So they put him on a mechanical device for resuscitation and brought him to the hospital. When he arrived at the hospital, as I said, already 20 minutes down the line without ROSC. So we put him on the table. We continued to massage him. I checked briefly what the problem was. The LAD is occluded, as you can see. And then before I opened the vessel, I introduced an Impella in this pain. Of course, in my hospital, Impella can be introduced within 5 minutes. So we introduced the Impella. I then opened the artery, put a long stent. Again, in this case, brought the patient back after a few days to optimize. So this was just the initial thing. After implantation of a stent, the patient could be defibrillated. He was with bad hemodynamics initially, but improved quite quickly. He also received a balloon pump additionally to the Impella. And the patient recovered well. Actually, now you will see it on social media. I just did a movie with him, a 3-minute movie, because the story is so incredible. Because he was resuscitated for about 50 minutes. So 50 minutes mechanical resuscitation, and the patient is doing very well. And in that movie, he's playing tennis. And driving a motorbike. So if I can conclude why I chose this, I chose it because I think we have to think beyond opening the vessel. We know opening the vessel does not always solve the problem. So let's think further. And I think one of the main things is let's discuss about hemodynamics. And I think in 2021, our job as cardiologists is not only to save lives, but we have to save hearts too. Because if we save a life, but the heart is destroyed, what can we do? And some patients will need more than opening a vessel. And I think using catecholamines in the setting of acute MI is not a good thing. But sometimes, of course, you have to do it. In our case, I think not using them and using mechanical support is a great thing. And it works very well. And I know it's expensive. And I know the companies need to be pressed to lower the prices for low budget countries. And this is, I think, an initiative we have to all undertake and work together. In my opinion, in acute MI, I have ECMO and I have Impella, but Impella is the tool of choice for such patients. And as you saw, we have quite good results. Of course, we need data for this. And I think that's the main thing that we need to generate this data as well. Thank you very much for your attention. And I hope you have some interesting questions.
Impressive talk. What I want to ask you is, having used all these mechanical devices, Impella, IABP and even ECMO, has anybody died during cardiogenic shock intervention of patients with cardiogenic shock? If they have died, why they have died?
Question. The problem is that not always you can save everyone. And the reason why they die are two. One is you save the heart, but the brain is gone when they are resuscitated. And this is probably the most frequent reason why they die. The patient who arrive and who have ROSC, or where we can generate ROSC, who leave the hospital, who leave the cath lab with an Impella and a relatively okay blood pressure, they usually survive. However, the problem is in those patients who have been out and resuscitated on the street, these patients can frequently die, but the problem is you don't know when they arrive how long they have been without brain perfusion.
Thank you.
We have ample time, on 5 minutes. I hope the audience, any questions from the audience? Yeah.
Thank you.
Yeah, Dr. Niyamali.
Yeah, can you hear me? Okay, thank you for that very interesting lecture. What I want to know is, now you seem to use Impella on nearly all your patients, except maybe when they have an LV thrombus. What percentage of them needed an IABP as well? And the second one is, did you use IABP alone in any of your patients?
Thank you for this good question. So in cardiogenic shock, Impella is the device of choice for me. In the very, very sick, before we switch them to ECMO, we would use IABP plus Impella. In patients who are in pre-shock, we use IABP only. Especially in those patients, for example, where we can open the culprit vessel, but where we feel they go for surgery. And we don't put a stent and say, okay, let's just increase some coronary perfusion. In those patients, we only use IABP. So if they are planned for CABG and we just open the vessel to stabilize them, they receive IABP and then they go for bypass surgery. But the regular shock patient in my hospital is treated with an Impella. And we treat, you have to understand, we cover a large region here. And of course, I live in a wealthy country. So in my hospital, we use about 80 Impellas a year. And 60 are for cardiogenic shock.
Now, in cases where you, after intervention, if they don't improve, have you used LVAD as a bridge for transplant later? What is the usage of LVAD in Switzerland?
So in my hospital, we don't have an LVAD program. So these patients, we would usually transfer to another hospital for LVAD. So usually they would go to Zurich. So what happens is we have them on Impella, see how they're doing, If they are improving, then we are taking the impella out. If they are not improving and need more support, then we either go to a 5-0 impella, so the large one for the left ventricle, or we switch them to ECMO, and then after switching them to ECMO, we transfer them to a center with LVAD, and then they usually receive an LVAD, and then if they are young, they go for transplant, and if they are old and or not suitable for transplant, then this patient would usually go then for a definitive LVAD. So they would be on the LVAD maybe for a few years until they die.
Dr. Flori, very interesting lecture, but I just want to add, there are some contradictory statements in the recent past by a few journals that they recommend that there's no place for ECMO or impella in coronary interventions, but is useful for surgeons. What is your comment?
I think, see, the problem is that we don't really have randomized data. So without data, we are just people with opinions. And I have my local data. My patients are all in a registry, and we have in Switzerland a nationwide registry for such patients. But of course, it's a registry, and we cannot guarantee that every patient is included. I can say for my center, where I include all patients in this registry, that actually the outcomes with impella in patients with acute myocardial infarction are quite good. So the examples I showed to you are not really picked examples. I have many examples like this. But of course, it's if you use it in the super sick, then you will have maybe less success percentually than if you use it a bit broader. So in my hospital, we use it in a broader fashion. So we don't even try to use catecholamines for days. So we would maybe, even in the cath lab, I would make the decision. When the patient arrives, I open the LAD and his blood pressure is 65 or 70. I don't wait for catecholamine to improve my situation. Then I would usually switch to impella right away. But this is a very pushy modern approach and supported by local data, which are fantastic. But I think we need broader data before we sell it. Today, I just wanted to stimulate you. I did not want to convince you to do the same as I do, but to stimulate a discussion, because I think it's worth having this discussion.
Yes, Dr. Chuchui, thank you very much. In the interest of time, we conclude this session. I thank you on behalf of Sri Lanka Heart Association for this very impressive lecture. It's a very grey area, and we were all a little confused with this. Anyway, thank you very much again.
Thank you.
Shall I start?